like now to talk about maintenance therapy in the treatment of patients with advanced non-small cell. 10 years ago, maintenance therapy was barely on our radar. Now we've had at least 3 separate trials that have shown not just a PFS advantage, but an actual overall survival advantage, 2 showing benefit for switch or continuation maintenance with pemetrexed, and 1 showing a similar benefit for switch maintenance with erlotinib, the Saturn trial. Mark, can you comment on some of these trials and how it's changed our standard practice?
Yeah, I think prior to the maintenance era, there were many trials that looked at duration of therapy using platinum doublets or triplets, and I think to summarize that data in 1 sentence, 3 to 4 cycles of platinum-based therapy seem to maximize the impact of survival response relative to the toxicities that you would get continuing multiple drugs beyond 4 cycles. And that kind of introduced the concept, well, what if you change your strategy after 4 cycles? And the initial wave of maintenance trials essentially took the 3 drugs that we had approved as second-line drugs, docetaxel, erlotinib, and pemetrexed, and moved them up earlier, after 4 cycles, in a population that had demonstrated some sensitivity to first-line treatment by virtue of getting through 4 cycles and not having disease progression, either stable or responding disease. And the initial trials with pemetrexed, both as a switch and continuation maintenance, did show survival advantages. And the initial trial, Saturn with erlotinib as a switch maintenance, showed a PFS and survival advantage. The Atlas trial that essentially was the same as Saturn, although it did look at a bevacizumab eligible population, showed a PFS effect, which was the primary endpoint, but not a significant impact on overall survival. Those trials led to the expansion of the label for both pemetrexed and erlotinib as maintenance. And so we kind of evolved into kind of this continuum of therapy from kind of first-line maintenance to second-line. One of the flaws in the design of all the maintenance trials was that there was an imbalance of exposure to multiple lines into specific agents. For instance, on both JMEN and Saturn trial, whereas 100% of the patients got randomized to pemetrexed on JMEN and erlotinib on Saturn. If you look at the placebo arms of those trials, only about 20% of patients ever received those drugs. So some have viewed it as not when you get it, it's if you get the active agent. And in fact, the only trial that controlled for what you got on the placebo arm was the Phidias trial, and the Phidias phenomenon, as I call it, was that if you got docetaxel immediately, or you got delayed
docetaxel,
as immediate docetaxel or delayed docetaxel,
sort of standard second line in
yes,
the control
yeah,
group.
and as long as you got docetaxel, at some point, your survival was identical, suggesting to me that there's not necessarily something magical about maintenance. What maintenance is telling us that it's important to get drugs that impact survival and quality of life in this population of patients.
But you can't be assured that everyone's going to go on to second-line treatment.
Exactly.
I think in the Phidias trial, 40% of the patients never
dropped
made
off.
it to
Yeah, and so that's why I think that maintenance is an affirmation that second-line therapy works. But your point, if you don't get second-line therapy, it can't help the patient. So in my practice, depending on how patients do through their first 4 cycles, they often will have cumulative toxicities or have a tough time. I'll give them a 6 to 8 week break, and then whether I put them on second-line therapy, whether you call that maintenance at that point or early second-line, it doesn't matter to me, but I know the patient's getting treatment. I don't necessarily wait for the standard RECIST criteria for progression.
I think if they haven't progressed, if they haven't actually manifested disease progression, you'd still call it maintenance, even if there was a small delay.
Exactly, exactly.
Mark, I'm sure I know the answer to this. You stopped the platinum after 4 cycles.
Yes.
Is that the case for everybody else? Is it 4 or 6?
4.
4? 6. I'm the outlier. Although sometimes it's 4. Certainly
Tell
the
me
data.
Who do you go to 6 on?
Everybody?
Most, not all.
Yeah.
What if they've stopped responding between 2 and 4, you still push it out to 6?
Potentially. Usually they're still responding though, between 2 and 4, or at least having some response. But your argument's well put. We've truthfully never had a comparison of 4 to 6. We have 4 to indefinite.
No, there was actually a Korean trial that was published in the JCO that looked at that question. If you were stable, if you were stable through 4 cycles, was there any value in doing 5 and 6? And the bottom line was that there wasn't. Yeah.
So I should change my practice.
Yeah. Yes, you should.
Certainly, there's problems with platinum if you go beyond
Yes,
4 to
yeah,
6. You
yeah.
have cumulative myelosuppression, you have a
Yeah.
heightened risk of hypersensitivity reactions,
Right.
and just progressive fatigue.
No,
So-
and it's, I think that's what, the trials of the 90s, so to speak, that there were 5 or 6 or maybe even 7 duration of therapy trials with either cis or carbo-based trials. And the lesson of that was that you didn't gain any more in response rate or survival, maybe a little benefit in PFS, but at the cost of cumulative toxicity, which I think was a detriment to the overall quality of life, because this is not curative therapy, right? I mean, we're trying to palliate people, maximize the survival benefit, maximize their quality of life, and minimize drug-related side effects.
And the benefit to pemetrexed was confined strictly to the non-squamous population.
Yes.
And that was carried over into the subsequent Paramount continuation maintenance trial. Govinda, do you routinely administer maintenance?
Yes, and non-squamous, non-small cell lung cancer.
And squamous?
Squamous, I don't.
So you'll stop after 4 or 6,
After
usually 4 cycles.
4 cycles.
And your
I
preferred
stop.
regimen is taxane carbo or gem carbo in that
In the
group?
frontline setting, I give paclitaxel carboplatin, old-fashioned.